Thank you very much for the opportunity to present today. And it's unfortunate that I can't be there with you in person as I would have loved to. And I want to say a very big thank you to Professor Murray, who has sort of mentored us and provided guidance to us since we started the African Palliative Care Association Comprehensive Chronic Care and Palliative Care within Primary Healthcare Reference Group at the APCA conference last year. So some of the work that I'm presenting in this presentation were work I co-led with Dr. Anna Pila from King's College London, and I'll be representing the reference group presenting these. Um, so thank you very much. So I'll be focusing on three objectives. How is palliative care integrated within primary health care in Africa? Three successful examples in different countries in Africa, and what really helps to facilitate, what are the facilitators for primary palliative care across Africa? Last year, we started a scoping review of integrated primary palliative care in low and middle income countries. And first, we started thinking around models because that is what um, was common. And we started thinking around models from person-centered community clinics to um, palliative care delivered by specialists or generalists within tertiary facility-based outpatient clinics, which were considered um, a sort of primary care. But then our thinking was challenged in terms of the possibility to be able to deliver palliative care effectively over the illness trajectory, over the illness course with single models. We know that single models will not be effective to really address uh, the patient suffering at different phases of the illness. So this helped us to shape our thoughts around thinking about pathways. How can we understand this data better in terms of pathways? So we looked at the data, and on the left-hand side, you have the data from Africa, really talking about how palliative care has been integrated from the home to the primary healthcare clinic to the secondary and tertiary facilities. And when we say primary health care, we are moving just beyond the setting of the primary health care clinic to really understand at what at where does primary health care really takes place. And we discovered that even within secondary and tertiary healthcare facilities, there are outpatient primary healthcare clinics that are run by multidisciplinary generalists, which provide care to people and serve as the first point of contact for a lot of patients when they need care. So, and we created this pathway. And when you compare that to the pathway for low and middle income countries, which is like a picture of where we should be aiming to get to. And on the left is where we currently are in Africa. And there seems to be a very big dependence on um, community volunteers and community healthcare workers. So in terms of three successful examples in different countries in Africa, the first example is coming from the Western Cape province in South Africa, where a consultant family physician and a consultant emergency physician with passion for palliative care decided to start and lead a holistic and person-centered approach to providing care for patients with life-limiting disease in primary care facilities. And this is the way primary health care, palliative care sort of started in many African countries with people who have passion for palliative care, trying to alleviate suffering. And after extensive community engagement and community involvement, um, there was also support from to the facility, from the facility management and sub-district management to make the work possible. And this we found is usually based on individual influence in sort of being able to advocate for resources and to ensure supporting policy is available. And the example from South Africa is really very strong, and this does not necessarily mean it operates that way across other different provinces in Africa. Another example from Malawi, which has really been driven um, by research from the Step Up project in 2013-2015, which targeted the provision of sustainable, accessible palliative care services for adults, children, and families through district health delivery systems in that 13 districts of southern Malawi. And this has more recently been expanded with the MapCare multi-country project, which is led by Kings and operates in 5 countries across Africa, and which focused on delivering palliative care within primary health care for elderly people with complex multimorbidity. And as part of this work, one of the successes from Malawi has also been Dr. Jim Bates' work in developing a unique tool to really measure the financial impact of serious illness on patients and families paying out of pocket. And that is published in the Lancet Global Health. And my research in Nigeria has focused on integrated primary palliative care for patients with serious illnesses, because we know that palliative care across Africa um, started with HIV and has expanded to cancer. But in the true principles of primary health care, we can't be disease focused in palliative care delivered within primary health care. So how could we expand our delivery to more conditions within primary health care, and especially in cases where these conditions, the patients might not even have a diagnosis of their conditions? These were some of the questions I tackled with my research in Nigeria. And I developed a feasible theory of change that highlights the assumption, the mechanism of actions, the critical indicators and outcomes that we need to focus on to deliver palliative care within primary health care. The training adopted a multidisciplinary approach to training development and implementation, and addressed some of the gaps in the WHO recommendation for implementation of primary palliative care, which was published in 2018 in terms of training um, and the differences between the training for nurses and for doctors and for community health workers, uh, which may not necessarily be feasible on ground. So we successfully trained primary healthcare providers within primary healthcare facilities to deliver palliative care. So thinking around what helps to facilitate the delivery of palliative care in primary care in Africa, and this is also from our scoping review of what integrated primary palliative care looks like across low and middle income countries, and extracting data, especially from Africa. We found that network with community level organizations, strong network with NGOs is very, very important to drive work and to ensure that other aspects of needs in terms of social needs, spiritual needs, psychological needs can be supported uh, adequately. There's also It's also of importance to capitalize on community values and uh, mutual support values that exist within African communities, and this helps to really drive community volunteering to and village healthcare workers to support patients who need help in their communities. There is also uh, willingness to engage with patients with unknown diagnosis. One of the first obstacles that we found when we started the work in Nigeria was that uh, primary healthcare providers felt that these patients with complex, serious illnesses should not be cared for at the primary healthcare facilities. And in some cases, these patients don't even have a diagnosis, and they cannot make the diagnosis of cancer at the primary healthcare level, or the diagnosis, a comprehensive diagnosis of heart failure at the primary healthcare level. So how do they then engage them? So we discovered that a willingness to engage patients for whom diagnosis may not even be known is very important to ensuring this. And also the need for proper referral network is really important to ensure that specialists are able to work with generalists and even community healthcare workers as well. There is a, a very important emphasis on ensuring that volunteer uh, uh, volunteers and community healthcare workers are able to work within their limited knowledge and skills, and they don't try to do more than they are trained to do or more than they are competent to do just because they are trying to help, and that they know when they need to refer. There are care guidelines to ensure that they can refer when they need to refer as well is important. And the need to also uh, embed traditional knowledge with modern practice is also very important in facilitating the delivery of palliative care within primary health care, and also the need um, to ensure that patients can continue to access their curative care when they want to and as they want to is also very important to ensure that they embrace palliative care at the primary health care level, because they emphasize the need to ensure that there is coordination of care, that what they will be told at the primary health care facility will not contradict what they will be told by their specialists at the teaching hospitals when they need to access that. And so those are some of the facilitators that were found. And we also found some challenges as well, which included ensuring that how do we define primary health care? Um, is it just about the level of the facility or the first point of access that patients have to care, which may be at the tertiary or at the secondary level in some cases? So I want to say a very big thank you to the African Palliative Care and Comprehensive Chronic Care and Primary Health Care Interest Group, and my colleagues from King's, collaborators from Edinburgh, from Malawi, from Ghana, from Nigeria, from Zimbabwe. I really appreciate all your support. Thank you very much.